I'm Dr. Brian Fowler from the University of Tennessee Hamilton Eye Institute in Memphis, Tennessee, and I'm here at ARVO 2018 where we presented a study. I think most of us in ophthalmology, one of the most rewarding parts of us going into this is that there's the opportunity to do work internationally, and this study really represents that, as we did this study with one of the doctors, Dr. Mandal, in Calcutta, India. So this was a collaborative effort between myself, Dr. Fleming, Jason Jensen, and Kendra DeAngelis, who are all from Memphis, with one of the surgeons over in Calcutta. What we're doing is looking at patients that have large eyelid tumors, particularly large upper eyelid tumors taking up more than 80% of the lid. And as many know that have tried to fix these, they're difficult, requiring a reconstruction of the upper lid after resection from a flap from the lower lid and cheek called a Cutler beard flap. The problem with the Cutler beard is that it does not replace the tarsal plate. And so there are a lot of options out there for replacing the tarsal plate. Some use ear cartilage grafts, some use hard palate grafts. There are synthetic materials called, one's called Tarsal is one of the more popular ones, Tarsys. This study was looking at using a silicone plate. Silicone, we know, is very well tolerated around the eye because it's used for scleral buckles and has been for a long time. In this study, actually, we took a scleral buckle, which is readily available not only in the United States but internationally, is very cheap, and can be fashioned into the shape and size of the tarsal plate. That scleral buckle silicone plate is then placed behind the skin of the Cutler beard flap, but in front of the muscle. So it places this silicone plate anteriorly. This study was a prospective study. It looked at 8 patients who had greater than 80% of their upper eyelid removed, and they had a modified Cutler beard surgery with the silicone plate. Interestingly, these patients did extremely well. One of the concerns when we did this was, would there be a risk of implant extrusion? And now, a year and a half into this study, with follow-up for all 8 patients, there's been 0 implant extrusion. There's been no infections, no complications, no reoperations. So we're a year and a half out, showing that this is a viable substitute for the tarsal plate. The second part of this is the functionality of the upper lid. So when we do this surgery, anyone that's done a Cutler beard, those eyelids sometimes are very functional, sometimes they don't move a lot, and that's related to the amount of muscle we're able to bring up into the lid, but also the viability of the levator muscle. In these patients, we had excellent outcomes with levator functions over 12 millimeters in every single patient, and margin reflex distances of 3 millimeters or greater. So, it's a valid substitute, it's cheap, it's easy to place, and it avoids the complications you have also with using another site. So a donor site like ear cartilage graft, a hard palate graft, those do have complications, albeit small, but there's risk of scar formation, granuloma formation, keloids, infection, and this avoids that completely. It also avoids some of the complications from grafts that are taken from cadavers, like Achilles grafts, with the risks of rejection associated with that. And then, unlike some of the other substitutes, the artificial synthetic substitutes, this is very cheap. So we found this to be an excellent modality for reconstructing the upper lid and reconstructing the tarsal plate in these very difficult to treat patients, not only to be used in the United States, but also overseas where there are limited means and access.